my name is Michael Johnson. This video will demonstrate the skill of chest decompression for the paper Contemporary Intensive Paramedicine. So yeah, let's get into it. So to confirm a tension pneumothorax, we will do obviously a force-seated exercise. And for this patient, what we would see in a tensioning pneumothorax is a decreased level of consciousness. We may see subcutaneous emphysema on the affected side, unequal chest rise and fall on auscultation, again decreased ear entry or nil lung sounds again on the affected side, and then potentially hyperresonance on percussion. In worsening signs of tension pneumothorax, what we could also see is jugular vein distension as well as tracheal deviation, and tachycardia with a falling blood pressure or hypotension as the patient deteriorated and as that tensioning side began to affect the heart. So come on round and we'll perform the skill. So my first step in actually performing a chest decompression would be the identification of the site of insertion. So the first site we can use is mid-clavicular line in the second intercostal space, and the second option we have is in the fourth intercostal space in the mid-axillary line. With either site, what I want to do is identify the site through the feeling of the ribs as we go down, and then also what we want to do is give it a good old swab with our alcohol. Once we have swabbed it, maintain the sterility of the site by preventing other people from touching it and things like that. So what we'll do now is we'll insert the needle into the chest. We've already given it a good clean, and we'll maintain the sterility of that site by just not touching it. I have a small scalpel here, and what we'll do is we'll just do a very small incision, sort of 1 to 2 centimeters down in the appropriate site, before just through the skin and through the adipose tissue before we actually get the Turkle needle out. Oh, got the Turkle needle out. And what we'll do is we'll just keep an eye on the green marker as we insert it. What we're looking for with that green marker is that as we begin to put pressure on the end of the needle, we start to see that it turns red. That's an indication that we're entering through skin, adipose tissue, muscle. Once we come through the other side of that, it returns to green, indicating to us that the pressure's been decreased on the end of that, or the tip of the needle, which means that we can then start to advance the catheter and remove the needle. Once that needle comes out, put that of course straight into the sharps container. And what we should hear from the end of this is a bit of a hiss, a bit of a roar, to indicate that the pressure is leaving that cavity and coming out into our atmosphere. Okay, welcome back. So we've got the catheter inserted in place, and what we're going to do now is just secure that with a small amount of tape. Just wrap that around a bit like the cancer ribbon, and then we're going to reassess the patient's airway, breathing with percussion and auscultation, looking for that return in ear entry or ear sounds to the affected sides, as well as a decrease in the hyperresonance during percussion. In regards to his tachycardia, we're hoping to see that come down, and with the potential hypotension, we're hoping to see that come back up. Hey, and on the flip side, if it hasn't improved, what we can then do is look at the second site or the alternative site, which is up here, mid-clavicular line, post reassessment of vitals like we just talked about.